He was 67 when his ophthalmologist first noticed the drusen, small yellowish deposits beneath the retinal pigment epithelium, the characteristic early finding of age-related macular degeneration. His vision at that appointment was 20 to 25, perfectly functional, good enough to drive, to read with glasses, to do every task his daily life required. His ophthalmologist told him the drusen were present, classified his condition as intermediate AMD, and told him to come back in a year. She mentioned the AREDS 2 formula, a specific combination of vitamins and minerals with published trial evidence for slowing progression. She wrote the supplement name on a card. He put the card in his wallet and never bought the supplement because he was not sure he really needed it, because his vision was fine, and because the conversation had lasted perhaps 4 minutes before the next patient was called. 7 years later, he returned to a different ophthalmologist in a different city. The examination was different this time. When he sat up from the slit lamp, he was told that his right eye had developed geographic atrophy, the advanced stage of dry AMD in which the photoreceptor cells of the macula have died in an expanding circle of irreversible vision loss. The central vision in his right eye was gone, not reduced, gone. He could still see the room, still find his keys on the counter, but the center of his visual field, the part he used to read a book, to see the expression on a grandchild's face, to recognize someone across a room, was an absence that no lens could correct and no treatment could restore, and the supplement he never bought had cost less than a cup of coffee each week. Age-related macular degeneration is the leading cause of severe irreversible vision loss in adults over 65 in the developed world. It affects an estimated 20 million Americans, with prevalence increasing sharply with each decade of life. Approximately 2% of adults in their 60s, 10% in their 70s, and nearly 30% of adults over 80 have some degree of AMD. The central vision that AMD destroys is the vision we use for reading, recognizing faces, driving, watching television, and performing virtually every activity that gives older adults independence and quality of life. Peripheral vision is preserved. The person can navigate a room, but they cannot see the face of the person in front of them. They cannot read a prescription label. The vision that remains is not the vision that matters for living. I am Dr. Edward. What you are about to hear is educational information based on published scientific research, including the largest randomized controlled trial ever conducted on nutritional intervention for eye disease. It is not a substitute for personalized medical care. AMD requires monitoring by an ophthalmologist, and the nutritional interventions I will describe do not replace that relationship. What they do is give you the specific biochemistry of why your retina is the most nutritionally vulnerable tissue in your body, which antioxidant your retina requires that most seniors are not providing adequately, and what the gold standard clinical trial shows happens when that deficiency is corrected. Subscribe to this channel right now before we go into the biology. The retinal science I'm about to describe changes not just what you supplement, but how you understand what is happening behind your eyes every single day. Subscribe now. It is free, and stay with me. Before I explain the mechanism, let me give you the AMD classification framework that most seniors never receive clearly at their appointments, because where you are on this spectrum determines your risk level and how urgently the intervention I'm going to describe applies to you. Early AMD is characterized by the presence of small to medium drusen and mild changes in the retinal pigment epithelium. Vision is typically normal. Most people with early AMD have no idea they have it unless a dilated exam finds it. Intermediate AMD involves larger drusen, more significant pigmentary abnormalities, or involvement of both eyes, and may produce subtle visual symptoms many seniors attribute to normal aging. Advanced AMD causes significant vision loss in two forms: geographic atrophy, the dry advanced form in which retinal pigment epithelium cells and photoreceptors die, leaving an expanding atrophic scar at the center of vision, and neovascular AMD, the wet form in which abnormal blood vessels grow beneath the retina, leak fluid and blood, and can destroy central vision rapidly without urgent treatment. The progression timeline is the critical clinical reality. The original AREDS study found that adults with intermediate AMD have approximately a 47% probability of progressing to advanced AMD within 5 years without intervention. Nearly 1 in 2, Drusen are not simply a finding to watch, they are a countdown whose speed is directly modifiable by the intervention I am going to describe. Let me explain why the retina is uniquely vulnerable among all tissues in the body, because this context is what makes the antioxidant deficiency so clinically urgent and the supplement recommendations so much more than general wellness advice. The macula, the small central region of the retina responsible for all sharp, detailed color vision, is the most metabolically active tissue per unit weight in the human body. Per gram, it consumes more oxygen, generates more metabolic byproducts, and maintains a higher rate of cellular activity than any other tissue, including the brain. Photoreceptors undergo continuous membrane renewal. Their outer segments, the light-sensitive stacks of membrane discs containing visual pigment proteins, are shed and regenerated daily in a cycle that never stops for the approximately 16 waking hours during which the eyes are receiving light. The retinal pigment epithelium cells supporting the photoreceptors phagocytose and recycle those shed outer segments in a continuous recycling process that no other cell type sustains at equivalent rates. All of this is powered by oxygen-intensive mitochondrial metabolism that generates reactive oxygen species as an unavoidable byproduct of cellular energy production. Compounding this intrinsic metabolic oxidative stress is the extrinsic stress of light itself. The retina is the tissue that light reaches and that photochemically transforms light energy into neural signals. High-energy, short-wavelength blue light at the 400 to 500 nanometer range directly generates singlet oxygen and other reactive oxygen species when it strikes photosensitive chromophores in photoreceptor cells, a process called photooxidation that is distinct from and additional to the oxidative stress of normal cellular metabolism. Blue light photooxidation operates continuously during any waking light exposure, indoors under artificial lighting, outdoors, through cloud cover and glass, and through the digital screens that emit concentrated blue spectrum light at close range for hours each day. Epidemiological research has found that cumulative lifetime blue light exposure is an independent risk factor for AMD, with each decade of high-intensity occupational light exposure associated with incrementally higher AMD risk. The total oxidative burden on macular tissue is therefore the sum of the highest intrinsic metabolic oxidative stress of any tissue in the body plus continuous external photooxidative damage from light. The antioxidant defense system required to neutralize this burden must be extraordinary. The human body has evolved one, but it depends entirely on specific dietary carotenoids that the aging body cannot synthesize, cannot substitute, and cannot obtain from any source other than food and supplements. When those carotenoids are absent from the diet, the macular oxidative burden accumulates without adequate neutralization. Photoreceptor cells sustain damage that triggers the drusen formation, and pigment epithelium changes that define AMD. And the 7-year progression clock I described in the title begins running. These carotenoids are lutein, zeaxanthin, and mesozeaxanthin. They are the only carotenoids found in the retina. They concentrate almost exclusively in the macula, forming the yellow-orange macular pigment measurable as the macular pigment optical density, or MPOD. They serve two irreplaceable functions. First, they absorb blue light before it reaches photoreceptor cells, functioning as a biological short-wavelength filter estimated to block up to 90% of incident blue light from reaching photoreceptors in eyes with adequate macular pigment. Second, they directly quench singlet oxygen and reactive oxygen species generated by both phototransduction and cellular metabolism, intercepting the oxidative damage before it can react with photoreceptor membranes and retinal pigment epithelium proteins. They are the primary antioxidant defense of the tissue most in need of antioxidant defense. They must come from diet. Every day, the body has no capacity to make them. Mesozeaxanthin deserves specific attention because its production declines with age in ways that lutein dietary analysis cannot detect. Unlike lutein and zeaxanthin, which are obtained directly from food, mesozeaxanthin is produced in the retina from dietary lutein through a conversion reaction that is efficient in young adults and becomes progressively less efficient with aging. Mesozeaxanthin concentrates at the very center of the macula, the fovea, which has the highest cone photoreceptor density and the highest light exposure of any retinal region, and is the first area to show damage in AMD. In older adults with low dietary lutein intake, mesozeaxanthin production at the foveal center is often the first component of the macular pigment system to fall below protective levels before the lutein depletion would be obvious on dietary analysis. Some supplement formulations include all three carotenoids. Preliminary evidence suggests that combined lutein-zeaxanthin-mesozeaxanthin supplementation produces superior MPOD restoration compared to lutein and zeaxanthin alone, which is biologically consistent with the specific role mesozeaxanthin plays at the foveal center where AMD damage begins. The clinical significance of macular pigment density has been established across multiple independent research programs over 2 decades. Lower MPOD is consistently associated with higher AMD risk, faster progression, and worse visual performance under glare and contrast conditions, even in eyes without clinical AMD. Research published in JAMA Ophthalmology found that adults in the lowest quartile of MPOD had significantly higher AMD risk than those in the highest quartile. The macular pigment is not a passive marker. It is an active protective factor whose adequacy directly determines whether the daily oxidative damage accumulating in the macula is being neutralized or allowed to compound over the years that separate intermediate from advanced AMD. Subscribe to this channel right now, because I am about to describe the clinical trial that changed the standard of care for AMD and the specific numbers I want you to have before your next ophthalmology appointment. Subscribe, it is free, and let us continue. The trial is AREDS-2, the Age-Related Eye Disease Study 2, funded by the National Eye Institute and published in JAMA in 2013, with 10-year follow-up results published in JAMA Ophthalmology in 2022. AREDS-2 was a multi-center randomized controlled trial enrolling over 4,200 participants with intermediate AMD or advanced AMD in one eye. It determined whether adding lutein and zeaxanthin to the standard AREDS antioxidant formula could reduce the rate of progression to advanced AMD. The results were definitive. Participants receiving lutein 10 mg plus zeaxanthin 2 mg daily had a 26% reduction in progression to advanced AMD over 5 years compared to those not receiving these carotenoids. Among participants with the lowest dietary lutein and zeaxanthin at baseline, the most nutritionally depleted group and the most representative of typical seniors who do not regularly eat dark leafy greens, the benefit was more pronounced, a 36% reduction in progression risk. The 10-year follow-up confirmed sustained progression risk reduction and measurably better visual acuity outcomes at 10 years in the lutein-zeaxanthin arm. The AREDS-2 trial also established that lutein and zeaxanthin should replace beta-carotene in the formula because beta-carotene increased lung cancer risk in current and former smokers and had no specific retinal mechanism, while lutein and zeaxanthin have direct blue light filtering and antioxidant functions specifically in macular tissue. The current evidence-based recommendation for intermediate AMD is the full AREDS-2 formula: lutein 10 mg, zeaxanthin 2 mg, vitamin C 500 mg, vitamin E 400 IU, zinc 80, and copper 2 mg daily, endorsed by the American Academy of Ophthalmology as standard of care. The AREDS-2 trial addressed existing intermediate AMD, but the much larger population of seniors without yet intermediate AMD, accumulating drusen, falling MPOD, and moving toward the 47% progression window, is where dietary and preventive supplementation matters most. Research from the Blue Mountains Eye Study, following over 3,000 Australian adults over a decade, found that higher dietary lutein and zeaxanthin intake was associated with significantly reduced AMD risk over the follow-up period. The Rotterdam study found the same inverse relationship. The POLA study in France found that high lutein and zeaxanthin plasma concentrations were associated with an 80% reduced odds of neovascular AMD compared to those in the lowest concentration quartile. These population cohort studies have observational limitations, but the biological mechanism is specific. The dose-response relationship is consistent across multiple populations, and the intervention carries no meaningful adverse effects. I want to address the relationship between AMD and the omega-3 fatty acid DHA because lutein and zeaxanthin are not the only nutrients the retina depends on, and the connection between omega-3 status and macular protection is something every senior taking a fish oil supplement deserves to understand more precisely. Docosahexaenoic acid, DHA, is the predominant fatty acid in the photoreceptor outer segment membrane, constituting approximately 50% of the total fatty acid content of the disc membranes that house the visual pigment proteins. This is the highest DHA concentration in any membrane in the human body. DHA's presence in the photoreceptor membrane is not incidental. The fluid dynamics of the visual transduction process, the conformational change of rhodopsin and conopsins that initiates the neural signal from light, depend on the physical properties of the membrane surrounding the visual pigment. A membrane rich in DHA is more fluid, more flexible, and allows the conformational changes of visual transduction to proceed with the speed and efficiency that normal vision requires. A membrane depleted of DHA and substituted with saturated and monounsaturated fatty acids becomes stiffer, less responsive, and impairs the kinetics of visual signal generation. Beyond its structural role, DHA is metabolized in the retina to neuroprotectin D1, a potent anti-inflammatory and neuroprotective lipid mediator that directly inhibits the apoptosis pathways that drive photoreceptor loss in geographic atrophy. Research published in the Archives of Ophthalmology found that higher dietary omega-3 fatty acid intake was associated with reduced risk of AMD progression, and the authors proposed DHA-derived neuroprotectin D1 as a primary mechanistic explanation. When lutein and zeaxanthin are protecting the macula from the outside, filtering blue light and quenching reactive oxygen species at the membrane surface, DHA and neuroprotectin D1 are protecting from the inside, maintaining membrane integrity and suppressing the apoptotic signaling that turns oxidative damage into photoreceptor death. The dietary science deserves time because most seniors leave ophthalmology appointments with a vague recommendation to eat more leafy greens that they apply half-heartedly and ineffectively. 2 points. The clinical literature is clear on that generic advice fails to communicate. The lutein concentrations needed to meaningfully raise MPOD are far higher than typical dietary intake delivers, and the bioavailability of lutein from different sources varies dramatically in ways that determine how much of what you eat actually reaches the retina. The richest food source of lutein is cooked kale at approximately 23 milligrams per half cup. Cooked spinach provides approximately 12 milligrams. Raw versions of these greens provide substantially less bioavailable lutein because cooking ruptures the chloroplast membranes that bind lutein in plant tissue. Eggs are important, not for their total lutein content, approximately 0.25 milligrams per egg, but for bioavailability. Yolk-dissolved lutein absorbs with approximately 3 times the efficiency of plant lutein bound to chloroplast proteins, making a single daily egg a meaningful retinal nutrition contribution despite its modest absolute lutein quantity. The fat solubility principle applies universally. Eating lutein-rich vegetables with dietary fat dramatically increases absorption. Research specifically examining this interaction found that carotenoid absorption from a mixed vegetable salad eaten with fat-free dressing was near zero for lutein and beta-carotene, while the same salad with full-fat dressing produced robust plasma carotenoid increases. Fat-free dressings on lutein-rich salads are, from a macular protection standpoint, exactly the wrong dietary choice for exactly the right dietary instinct. I also want to mention astaxanthin, a marine carotenoid from Haematococcus pluvialis algae found in salmon, shrimp, and krill, because it has emerging evidence as a complementary retinal antioxidant working through a mechanism that lutein and zeaxanthin cannot reach. Astaxanthin does not accumulate in the macula or filter blue light. Its specific role is in mitochondrial protection, quenching reactive oxygen species within retinal cell mitochondria, protecting mitochondrial membranes from lipid peroxidation, and maintaining mitochondrial function under oxidative stress conditions that would otherwise trigger the photoreceptor apoptosis that drives geographic atrophy. Research published in the Journal of Clinical Biochemistry and Nutrition found that astaxanthin supplementation improved retinal capillary blood flow and reduced oxidative stress markers in the vitreous humor of AMD patients. At 6 to 12 milligrams per day from a clinical-grade hematococcus-derived supplement, astaxanthin represents a meaningful addition to a lutein-zeaxanthin protocol specifically for seniors with intermediate AMD or significant AMD family history, addressing the mitochondrial oxidative component that macular carotenoids alone cannot fully reach. I want to spend a moment on the genetics of AMD because understanding your genetic risk changes how urgently you should be acting on what I have described. Variants in several genes, most significantly CFH, ARMS2, and C3, substantially increase lifetime AMD risk. Approximately 50% of the genetic risk for AMD is attributed to common variants in the complement factor H gene alone. Seniors with a first-degree relative who developed advanced AMD have roughly a 50% lifetime risk themselves, compared to approximately 12% in the general senior population. If you have a parent or sibling with AMD, particularly advanced AMD, your MPOD, your retinal carotenoid status, and your dietary and supplementation protocol are more urgent, not less, than for someone without family history. Genetic testing for AMD risk variants is available through several direct-to-consumer and clinical genetic testing services. Knowing your genetic risk converts the interventions I have described from general senior health advice into a specific protective program calibrated to your personal AMD vulnerability. There is one more risk factor I want to address because it has a specific and under-recognized relationship to AMD that goes beyond the general health consequences most seniors have been told about: smoking. Smokers have a dramatically elevated AMD risk, approximately 2 to 4 times higher than non-smokers in most epidemiological studies. The mechanism involves both direct oxidative damage from cigarette smoke constituents and a specific depletion of macular carotenoids. Research has found that serum lutein and zeaxanthin levels are significantly lower in smokers than in non-smokers at equivalent dietary intakes because the oxidative burden of cigarette smoke depletes circulating carotenoids faster than they are replenished from dietary sources. Smokers who also have drusen are therefore carrying compounded AMD risk, higher baseline oxidative stress driving faster drusen growth, depleted macular pigment providing less protection against that oxidative stress, and each factor accelerating the other. For seniors who are current smokers with any AMD finding, the priority before any supplement discussion is cessation because no MPOD restoration program fully compensates for the ongoing carotenoid depletion and oxidative burden of continued smoking. For seniors who are former smokers, your historical smoking burden created a period of accelerated macular pigment depletion that may not have been fully restored, making a higher supplementation target and more frequent MPOD monitoring particularly appropriate. I also want to speak directly about something that most seniors with AMD do not know and that most ophthalmology conversations do not have time to communicate adequately: the asymmetry of AMD. AMD rarely presents identically in both eyes. The common pattern is for one eye to be more advanced than the other, and because the brain effectively compensates for the worse eye by relying on the better eye, many people with advanced AMD in one eye have no idea their vision has changed until their better eye has a problem and they cover it, and suddenly the absence that has been growing in the other eye for years is fully visible. This compensatory blindness is why regular monitoring is not optional, even when your vision seems fine. And it is why MPOD measurement and AREDS2 supplementation is appropriate in both eyes, regardless of which eye currently shows more AMD changes, because the worse eye shows you where the better eye is going if the protective intervention is not in place. Now, before the action protocol, this is the moment to share this video. The man in my opening story had a card with a supplement name in his wallet for 7 years. The person in your life who has been told they have drusen, who left an appointment with a supplement recommendation they have been meaning to look into, who has a parent who lost central vision to AMD and assumes the same is coming for them, is carrying their own version of that card. Share this with them now, not after the summary. While the 47% 5-year progression risk and the 26% AREDS2 reduction are specific enough in your mind to make the conversation feel urgent rather than optional. Share it now. Then come back for the complete protocol. Here is what to do in the next 48 hours based on everything you just learned. Today, find out when you last had a comprehensive dilated eye exam. Not a vision screening, not a quick visual acuity check at a primary care visit, but a full ophthalmological examination with pupil dilation. The only examination that can detect drusen and assess macular changes. If it has been more than 1 year since your last dilated exam and you are over 60, schedule one this week. If you have previously been told about drusen, early AMD, or any macular changes, schedule with a retinal specialist rather than a general ophthalmology or optometry practice. This week, begin lutein and zeaxanthin supplementation regardless of whether you currently have AMD. For adults without AMD, a supplement containing lutein 10 mg and zeaxanthin 2 mg daily provides the AREDS2 trial concentration without requiring pharmaceutical formulations. For adults with documented intermediate AMD, the full AREDS2 formula, available as named AREDS2 brands at most pharmacies, is the American Academy of Ophthalmology endorsed standard of care. Take the supplement with your largest meal of the day to maximize fat-dependent absorption. Also, begin the dietary adjustments. Cook spinach or cooked kale at least 4 days per week, 1 whole egg per day if your dietary and medical history permit, and olive oil-based dressings on every vegetable-containing meal. At your next eye appointment, ask specifically for a measurement of your macular pigment optical density using heterochromatic flicker photometry. An MPOD below 0.3 log units indicates significant macular carotenoid depletion requiring aggressive intervention. An MPOD above 0.5 log units indicates meaningful blue light filtering protection. Ask your ophthalmologist where your MPOD falls on the normative curve for your age and whether your current supplementation regimen is appropriate for your AMD stage. You now understand that the macula is not simply the center of your visual field. It is the highest metabolic demand, highest oxidative stress, highest light exposure tissue in your body, a tissue whose entire antioxidant defense system depends on dietary carotenoids the body cannot make, cannot substitute, and cannot recover from the loss of once the photoreceptors they protect have died. A 47% 5-year progression probability for intermediate AMD without intervention. A 26% reduction in that progression with the specific supplement tested in the largest nutritional eye trial ever conducted. A window that closes as atrophy spreads. Now you know what to put in the window while it is still open. Subscribe to this channel if you have not already. My next video covers the 4 other nutrients with the strongest retinal protection evidence, including the omega-3 fatty acid that constitutes the majority of the photoreceptor outer segment membrane, and whose deficiency in most seniors is accelerating the photoreceptor loss that lutein and zeaxanthin are trying to prevent. Subscribe so it comes directly to you. I am Dr. Edward. Your central vision is built from what you eat. Feed it correctly. I will see you in the next one.